That's awesome.
So all right, guys. Thanks for joining our grand round session tonight. We're fortunate enough to have Nick Smith with us. He's a great plastic surgeon. He lives in Adelaide, but he's also spent some time in Perth, and he specialises in hand and finger injuries. So I'm gonna pass you over to Nick to do his presentation. If you've got any questions, just chuck them in the chat. We'll get to them along the way. There'll definitely be time at the end for questions as well. So thanks so much, Nick.
Yeah, thanks for having me, Jarrod. Hi, guys. Thanks very much. I was just going to talk today about hand injuries in children, basically, but it sort of applies to young adults as well, or anyone who's sort of playing sport on the weekends or doing anything. If you've got any questions, just feel free to unmute yourself and yell out if I don't notice you, because I'm pretty tunnel vision, so I might not notice hands up or anything. So a little bit about my background. This is where we work in Adelaide. We're at Grip down in the city. We're looking to sort of move, and I'm trying to get them up to the hills because I grew up in the Adelaide Hills, which is amazing. This is our team. Paul Van Minnen started the practice. He's a Dutch surgeon, and we've got 4 hand therapists and other staff members. So we just do hand and wrist surgery down in Adelaide. This is our building, our COVID safe space. Our hand therapists are really probably the backbone of our service that we provide, in that you can't really do hand and wrist surgery without hand therapy, and they see a lot more patients than I do, and they help out a lot more GPs than patients I see. So I just can't speak highly enough about hand therapy generally, and this is sort of a project we've got going at the Women's and Kids and the Royal Adelaide, is trying to increase the FTE of hand therapy. So yeah, if a take-home message from today would be involve hand therapy as much as you can. We've got 4 practices for hand therapy around Adelaide that's sort of relevant for the people in Adelaide. And Paul and I have been working together for about 10 years at the Royal Adelaide Hospital, and I've just joined him in private practice. We only do hand and wrist surgery and peripheral nerve surgery. So it's just, it's what we're interested in. We do a little bit of teaching. So the guys from Interstate, there might be some people that you recognize. We sort of do teaching for plastic surgeons and orthopedic surgeons that want to do hand and wrist surgery. And if you need any handouts for patients, I'll just quickly mention on our website, you can click on, for example, carpal tunnel syndrome. There's a few more expanding with this, but if you need a handout about driving or, what to expect after surgery, feel free to sort of grab these and scrub our names off it and hand it to your patients. It's very standard stuff, but I find the patients like to chuck it on the fridge and just have a read. So active children is something I'm really interested in. I work at the Women's and Children's Hospital, and it really covers every child, basically. I mean, an active child, children start moving even before they're supposed to start moving. And I've got a 3-year-old daughter, and so I'm sort of rapidly learning how active children get when they're sort of infants and toddlers. And then, that goes all the way up to professional athletes, really. And there's lots of teenagers playing in the AFL and similar kind of professional outfits. So we see all of those injuries from the 0-year-olds to the 17-and-a-half-year-olds, and that it covers the full spectrum of hand and wrist surgery, really. So that's probably what you can expect coming through the private, through the GP practice is anything involving those patients. A few really common things I was going to chat to you about today, which are the things that we see through the Women's and Children's Hospital and probably reflect the phone calls and advice that we would give to the various GPs who call up with patient problems. So nailbed injuries, very common, mallet finger, PIP joint, which is super important, proximal phalanx fractures, which I've got a special interest in. Thumb UCL is something I get a lot of questions about, metacarpal fractures, and then wrist sprain. And then just some specific kind of pearls about treating children with hand injuries. So any questions about these, just chime in whenever you like. So this is a classic nailbed injury. So say you have a child who's stepped on a socker, or could be slammed in a door or slammed in a car door, and they present with a finger that was bleeding, but it's not bleeding anymore. It's super sore, very upset child, and the parents are wondering what we should do about it. The nail bed is this sort of ultra-specific anatomical structure in the at the end of the finger, and it's really functional. So you need your nail to pick up things like coins. And the nail bed, the thing that sticks to the nail plate but is on top of the bone, is very, very specific tissue that we almost can't replicate any other way. So when it gets damaged, we like to repair it nicely because we can't really make it very well. And if someone loses a nail bed, sometimes we have to steal something from the toe, or we just have to get rid of it completely. So we're very interested in trying to preserve it as much as we can. But underneath it, it's sort of complicated. So there's the bone, which is very, very close to it, an extensor tendon over the top, a flexor tendon down the bottom. So there's a lot of things going on here anatomically, and it can kind of confuse the situation. And it means you get the full spectrum of injury, from something that's simple and completely ignore and give someone some Panadol and, you know, put them in a car seat and go home, to something that probably needs to go and have an operation at a children's hospital, wherever you are. This is the spectrum that we see. So on the left-hand side, you see someone who's definitely got a nail bed injury. So anytime you've got a bruise or blood under the nail, that means that the nail bed has been cut, because that's the only thing that can bleed underneath. But the epinicium, which is the bit of skin that's proximal to the nail plate, where the germinal matrix is, which makes nail plate and pushes it distally, looks really nice. So there's wrinkles in it, meaning it's not too swollen. It doesn't look out of place. There's smooth contours, and this is just a subungual hematoma and not very tense. Something like that on the left-hand side, I'd be happy to just reassure them, probably wouldn't even get them an x-ray if it was simple like that, and just send them home and say that, you know, that bruise is going to be there for probably a few months. The nail may lift off, may fall off, but they just need a dressing and they don't need antibiotics. This is a closed injury on the left-hand side. So there's no signs, there's no bleeding here outside of the nail. There's no signs that the nail root's been avulsed. So that's a closed injury. In the middle, you see that they become more severe. So the difference here is, one, there's a lot more blood under the nail plate, firstly. So you can't see any normal nail bed. Secondly, it sort of looks like it's out of position, and it particularly looks out of position proximally where the nail root is. And that's a really annoying thing that can happen, because sometimes it tricks us. Sometimes they sort of look normal. And also there can be complications when you have a nail bed injury that's proximal. So the distal, over the sterile matrix, which is over the distal part of the nail, that's pretty straightforward about what needs to happen. But when germinal matrix is involved, or when the nail root is involved, you can get delayed complications if an injury is missed. So if you see something that's tense and shiny and there's lots of blood on it, and the nail doesn't quite look like it's in the right place, it sort of looks like a bad drawing, then I'd probably flag that with a local children's hospital, or talk to a specialist about it. And then the right-hand side, I mean, that is a nail bed injury as well, but that's really a subtotal amputation. So that's pretty standard thing to present to hospital, and you'd get a specialist review of it. The picture on the middle associated with a fracture underneath about 50% of the time. So if you get a bad nail bed injury, don't feel bad about sending them for an x-ray. It's pretty low dose of radiation just to the distal phalanx. We only need one x-ray, and that'll sort of guide treatment and how long they need to wear a splint for. And this is what you find in those three cases when you take, under a general anesthetic, you take the nail plate off. So simple case where maybe there's a little bit of blood or a lot of blood is a nail bed laceration, and we give it a really good clean, wash out the fracture underneath and put some nice sutures in. Then we just place the nail plate back underneath the epinicial fold as a sort of a biological dressing, and let it fall off later. The case in the middle, so the case where it looks like there's a nail root avulsion, super important. So this is, you have to do relaxing incisions, but this is a germinal matrix problem. And the reason this is a problem is that if, for example, that nail plate came off and you were looking at that normal nail bed, it almost looks completely normal, and you wouldn't go exploring underneath the epinicial fold. But it's super important that you do, and we'll come to that. That's what a Seymour fracture is. So if I can, one take-home message from this is, if you think the nail root is involved, it's good to just flag that with a specialist just to exclude a Seymour fracture. And number three, well, that's a sort of a disastrous injury. It obviously has to have an operation and a very specific reconstruction and close follow-up, because they can get nail bed changes, they can get painful nail spikes, and they probably need follow-up for, 6, 12, 18 months afterwards. An interesting thing with children, this is a photo, I think, of a teenager, not my photo, but is composite grafting. So composite grafting is if you cut a piece of the body off and it involves more than one tissue, we call it composite, meaning two tissues. So if you cut a bit of the finger off, bit of the nose off, and it's got cartilage and skin in it, or a bit of muscle and skin, or fat or skin or whatever, that's composite, more than one tissue. If you cut it off and it's clean and the person's young and they're not a smoker and there's no weird vascular diseases, you've got a chance to put this back on as a full thickness graft. And we call that composite grafting. And the chance of that working in an adult is not that high, to be honest, almost sometimes not worth it. But the chance of it working in a child actually becomes higher and higher and higher the younger they get. And this is really important because sometimes children will present to a GP practice having had an injury with a piece of something. And the piece of something can look like nothing or a bit of hamburger that, the dog was eating last night. But all you need to do is put that in a little plastic bag, put the bag in a little bit of slushy water and send it in with the child. And we'll have a look at it in theatre with our loops and decide whether you can put it back on. And a lot of the time we'll try and put it back on first. So this is a child, I didn't have a picture of a finger, but this is a child that we did who was bitten by a dog. And the dog was chewing up the end of his nose, but the mum was good enough to open the dog's mouth, go and get the end of the piece of nose and send it in a little bag. And this is, if you didn't have that nose, that reconstruction becomes really, really tough and kind of prolonged, and it would probably take 2 or 3 operations to get right and would never look normal. But we have a chance, even when this has been inside a dog's mouth, after we clean it, the surgery is super simple. We just stitch it down and let the blood supply grow into that piece. And children have such regenerative ability that you can get these pieces of tissue to take. And if it's like this or the end of a finger and they get a result like this, that's a really fantastic thing that's happened for that child. So if you do ever get a piece of something with a child, just send it in. You won't look silly at all. Even if it was, even if it was a leaf at the park and you accidentally thought it was a finger, just send it in. We'll figure it out. And they can get really, really good results. So back to this Seymour fracture just briefly. So if you get a nail root avulsion and the x-ray sometimes looks like this. So this is a fracture through the growth plate and there's a tilt on the distal phalanx. The issue is that proximal nail fold that's hidden underneath the epinicular fold, that proximal nail bed, can get stuck inside that fracture. And no one really notices for about 6 to 8 weeks because the fracture's not healing and it's causing the finger to become swollen and stiff and sore. And it might be, a bit purulent or whatever, but actually that's how nailbed injuries heal as well. So it takes 2 months before someone decides, this is actually not healing as it's supposed to heal. And they realize that it was a missed Seymour fracture. And these children get osteomyelitis and have to have a number of operations and get fixed. So that's why proximal nail fold, any hint of a Seymour fracture, just refer them in, have no fear with doing that. And we'll take care of it. So moving on to mallet fingers. Mallet fingers are these seemingly small injuries that I spend absolutely hours on counseling patients and talking to patients and following them up. Classic case is getting hit on the end of a finger and then they've got a lag on their finger. And it's a really simple idea. The tendon, the extensor tendon, which starts almost at the elbow and goes all the way down the end of the hand and attaches to the distal phalanx, has been pulled off. And that leads to you being unable to extend the distal phalanx of the finger. And that really kind of balanced extensor tendon apparatus becomes unbalanced. They come as closed or open. The open ones are actually more simple to deal with because you can put anesthetic in them, debride them, fix the fracture or fix the tendon, and then close the skin over the top. The closed ones, we just manage with a splint. So we put them in a splint. And if we choose a splint or surgery is basically based on whether there's a bony fragment involved and how big it is. So the bigger the bony fragment is that comes off, the higher the likelihood of us doing an operation straight away, because the collateral ligaments that attach down the sides of the distal phalanx are actually attached to the bony fragment, not to the distal phalanx. And so the distal phalanx falls out of position. So in that space, if the joint is subluxated, out of position, then you have to fix them. But before that, we'll try as hard as we can just to splint these. This is the splint we put them in. Again, a hand therapist can make these, we have mallet splints in ED and things like that. They're okay for a few days. But if you have a hand therapist or a physio that can make a thermoplastic splint and fit it to their finger, it's much more comfortable and much easier at holding the finger in a good position. So that's what I would recommend. And we fix them a number of ways. Sometimes we put KYs in them in children, and sometimes we sort of put a little plate in them, but the plates can cause problems and sometimes need to be taken out. The group of patients I'd be really careful with mallet fingers in treating them is people with ligament laxity. So this is notoriously young women, so girls, and they have very lax volar plates. They can stretch their elbows, stretch their fingers everywhere. And the problem with that is that when you unbalance the extensor tendon apparatus, so the EDC at the very end comes off, the central slip becomes the first bit that tightens when they extend their fingers, and their volar plate doesn't hold their finger in position. So they start to get a swan neck deformity of that finger. And you don't notice that straight away. So when someone comes in, put them in a mallet splint, not a problem. Finger looks okay. You notice it at sort of 3 or 6 months down the track when it is a true swan neck deformity. And then it's a little bit more complicated to treat and involves some more surgery. So if there is any hint of ligament laxity, it's almost worth having a specialist review just to counsel the patient about what they might expect and the natural history of mallet fingers, which is, and this is what I say to patients, after absolute optimum treatment, you can expect 10 to 15 degrees of lag at the DIP joint. So it's very rare that someone will have full extension at the DIP joint after a mallet finger. And if they do, that's a fantastic outcome. But 10 to 15 degrees is probably baseline. PIP joint. So if we move one joint back in the finger, the PIP joint is the middle joint on the finger. Super important joint for flexion of the fingers. So if you look at your hand and you make a fist with your hand, 50% of the movement of your finger is from the PIP joint. So if you have a stiff PIP joint, you'll lose 50% of the movement, and if you injure it, and that's really, really noticeable to patients, much more noticeable than having less movement in the MCP joint or the DIP joint. It's also the one that in ball injuries tends to go. So a ball injury on the end of the finger will pop the PIP joint out. Very, very common. This is a netball injury or a footy injury. They get a little bit of bruising of the finger. They're a little bit guarded in how they move it, and they're quite swollen, but not necessarily rotated. And they might even have a stable joint if you move it through range of motion. It's again the same idea as the DIP joint. So the whole tenet of PIP joints hangs on where are the collateral ligaments. And if the collateral ligaments, which run down the side of the joint, are mostly attached to the big bone, the middle phalanx, then it will hold that joint in position, and you should be okay with therapy with a dorsal blocking splint or a bit of buddy strapping. This is what we commonly see at the kids. So left-hand side, very small fragment where the volar plate's been torn off as the joint dislocates backwards and then it pops back in. But you can see the head of the phalanx, of the proximal phalanx, and the base of the middle phalanx are congruent. So they've got nice train track lines that are running. This is good for therapy. That joint's stable. The photo, the x-ray in the middle, you can see that the dorsal aspect of the joint has a V sign. So that's a black V, meaning that those joints are not congruent anymore. And that means no matter what, that joint is subluxated, that's out of position. And they're going to have a compromised outcome unless that's changed, because the joint will hinge at a different position and they'll start to get a bit of arthritis. And that probably doesn't happen straight away. That happens in like 6 months' time. So if you do N-locate one of these joints, if you pop it back in ED and you get a lateral, and the lateral doesn't look like it's completely N-located, I'd recommend having someone have a look at it. And then on the right-hand side, obviously, if you take a massive piece off and the whole thing's sort of destructed, then they need quite complex surgery, and the outcomes are very grey zone. So for the right-hand picture, you'd lose about 50% range of motion of that joint with best possible case with surgery.
Nick, if you're on the side of the footy field and a 12-year-old does it, and they come over and go, my finger's out of place, can you put it back in? Would you put it back in or suggest go to ED for the X-ray first?
I would. I'd give it one go at putting it back in. The difference with kids is sometimes they fracture through the growth plate. So with an adult, so if you've got a big boy you're on the side of the oval and like the Mount Lofty A grade are playing, and some big carpenter comes to you with these huge bones and says, my joint's out of position, give it a go, put it back in, because he's likely done a ligament because his bones are so strong.
Yeah.
The slight difference with kids is that they've got a growth plate and their bones are a little bit thinner. So there's a higher chance that they've either fractured their proximal phalanx or middle phalanx. If they're tough enough that they want to give it a go at putting it back in, if you're reasonably confident in your abilities and not too rough, you can give it a go at putting back in. And if you pop it back in, beautiful. But if it doesn't go back in straight away, or if it's a bit difficult, then I'd just hold off and I'd get an X-ray, because it probably means it looks like a dislocated joint, but it's actually a fracture somewhere else, which is what we see quite commonly.
Yeah.
And you don't want to have a go 4 or 5 times putting it back in, because you'll just cause them pain and you'll fracture it a bit more.
Yeah.
But gross majority get this. So this or buddy strapping is the way to go. You just protect the volar plate. They flex in that. They do this for about 6 weeks, and then they're back to sport. Proximal phalanx fractures I'm super interested in, and I realize how disappointing that sounds. Like, I can hear how bored people are when I say that, and I almost can sense the boredom in myself. But it arose from seeing a lot of AFLW injuries about 5 years ago, when AFLW in Adelaide really picked up in the amateur league. So this is how it presents. Child falls over, they have wonky fingers, they're very sore, and they've got limited range of motion. And on the limited range of motion, you can see there's something not quite right about these fingers. They've got some scissoring, or they're sort of deviated. This is what I'm talking about with the growth plate fractures. So if you put stress on a finger in a certain position, it will fracture through the weakest place, or it will break through the weakest place. So in big burly men, that's going to be around the joint, because their bones are so strong that the ligaments now become the weakest place. In smaller women who perhaps don't do a lot of manual labor, or with finer hands, they might fracture bones. And in children, that's growth plates. So I think probably 85 to 90% of the fractures that we would see in children with open growth plates are through the growth plates. We call them Salter-Harris fractures. That's sort of how they're classified. But Salter-Harris 2 is the most common, and that's through the diaphysis, so through the middle of the bone a little bit, and then down through the growth plate. So if you see a deviated finger in a child that's quite young, so maybe 12 and below, open growth plates, lots of growth to go, I would assume it's not a dislocated joint. I would assume it's a Salter-Harris 2 fracture. And that might change whether you do like a reduction before an X-ray or an after an X-ray, because if you reduce it probably and do an X-ray, you might not know there's a fracture there, but it might just change the way you manage that patient. With all these fractures that came through in women, we sort of started to get an idea that women's proximal phalanxes might be a little bit different to men's proximal phalanxes. And this study is sort of in older adults, or older adolescents, so 15 to 30. But we had a look at CT scans done through the Royal Adelaide and Women's and Children's Hospital of proximal phalanx fractures, and we measured the size of their proximal phalanxes in men and women, basically. Measured the length of it, the width at the head and the middle and the base, and then took an axial plane and measured the cortical width of the bone, which is a critical measurement for strength. And we compared men and women, so absolute lengths and then ratios of length. So if a proximal phalanx was longer or relatively thinner or something like that. And what we found probably explains the injuries that we see in proximal phalanx fractures. So women overall have smaller proximal phalanxes, which is straightforward. So the head was narrower, the width was narrower, the base was narrower, about 20%. But the length was 10% shorter, and the cortical width was significantly thinner. So the cortex at the middle of the phalanx was about half what it was in men. But if you compared the ratios of how these proximal phalanxes were built, The women's proximal phalanxes are relatively longer and relatively narrower than men, with a significant difference in cortical thickness. And that means that the ligaments around their joints start to become relatively stronger. So that's the strong part of the finger, and the relatively weaker part of the finger starts to be the bone. And that's why we were seeing I think, a lot of nasty bone fractures in women. And these were adolescents and women in their 20s who are really busy with their hands, often working full-time or with young families. Super important patient cohort to get right. So that's just something that we were looking at. And it probably reflects, this is a gentleman, Jason is an orthopedic surgeon in Melbourne, but he audited his AFL injuries in men and women, and the AFL men had a greater chance of having a ligament injury around the fingers, and the AFL women had a greater chance of having a fracture. So it's just sort of an interesting idea of what might present in women and men, and that's a little bit different. But the Saltaris 2 fractures, so super common, about 85%, we manage on examination. So if a person comes in and their finger's not rotated and it's not too deviated, we'll leave it alone. But if it is, then we have to correct it. And usually we correct it and put a little wire in it as well. And that wire stays for 4 to 6 weeks. And then at 6 weeks, they're back to sport. Obviously, there's a spectrum. This is a young girl that we did a couple of weeks ago, but as the fractures become more complicated, they need more complicated metalwork. And this is not a decision that's sort of made lightly, but this person had very bad fractures of 2 proximal phalanxes after a car accident, and they need to be fixed properly. Sometimes the metalwork has to be taken out, but this is the best chance they have of getting good range of motion afterwards. Metacarpal fractures. So we see them really commonly in adults, so punch injuries. But they're just as common in children, and they can happen for a number of reasons. A lot of the time it's a torsion injury to the hand, which is twisted, or blunt trauma to the back or the front of the hand, or punch injuries as well. Increasingly, and it comes from the UK literature, but increasingly we're managing metacarpal fractures non-operatively. And that's because the absolute end of the line reason for that is that they get very good results non-operatively. And so the risks of surgery are not worth it to potentially increase their function. So these are 2 metacarpal fractures that we're managing non-operatively in the last week that we've seen at the kids. One's a 5th metacarpal neck fracture from a fall with a clenched fist, and one's a 3rd metacarpal sort of short oblique fracture. So if a child comes in like this, we just look at the hand, get them to extend the fingers, see if they've got any lag. So if the metacarpal's really shortened, and that fracture's crunched down, sometimes the finger doesn't fully go up. That's one reason you might fix it. Then I get them to turn over the hand and make a fist and see if there's any scissoring. And if it looks like there's no scissoring, no rotation, and not too much lag, then we'll manage that conservatively, and it's almost irrelevant what the fracture looks like. And there's going to be some caveats with that. So if there's an open fracture, we always fix those. And if it's very disastrous or the bones are in a different suburb, then we'll need to fix them. But if it looks like this and they examine well, then they get left, and the children do really, really well. The reason they do is that there's a deep transverse metacarpal ligament that holds those metacarpals in place. So the best chance you have of a fracture being managed well non-operatively is in the 3rd and the 4th metacarpal, because they've got one either side, but it also can happen in the 5th and the 2nd. And we get that from the UK, where they're increasingly trying to manage everything non-operatively because they struggle for theatre time, and their results are very, very good. So this is a case I saw yesterday. This is a girl who had sort of a spiral 3rd metacarpal fracture from a torsion injury to her hand. We had a look at her hand. She had straight fingers. She turned over, no rotation. Put her in a splint with a hand therapist. It's a beautiful thermoplastic splint. Leave it on. She can do some exercises in it, and then she comes back at 6 weeks. And she's a little bit sensory, so she didn't like the splint very much, but really good result. She can curl the fingers under. She just didn't want to. And then we basically say goodbye to them. So we don't really do any more x-rays. We just manage them clinically at that point. touch over the metacarpal, not too much pain, it's healed, and then they go and they do really well. But a similar case, so if this person came to you, this must be like a 17.9-year-old man, but if he came, you can see, well, maybe the ring finger might be pointing in a different direction, although it doesn't look too bad there. X-ray is not too bad. Probably manage that X-ray conservatively. But if you turn him over and make a fist, and that ring finger is trying to, go down the other side of the street, then probably that's something that's not going to be managed conservatively or non-operatively, and we'd need to correct that. Probably better to correct that now than having to do an osteotomy down the track. And so the way we do that is either with wires again, or if they're old enough and we're away from the growth plates, we can also put screws in. That has the benefit of not having to take the wires out, but they get a scar. Thumb UCL injury is something we see really commonly in people who dive. So cricketers notoriously come in having tried to catch something in the slips and get a lot of pain around their thumb joint. And the question always with thumb injuries is when do they need to see a specialist, or when do they need to get operated on? So what's interesting about the fingers is every finger joint has a radial collateral ligament, so RCL. So the DIP joints, the PIP joints, the MCP joints, everything does. And every finger joint has a UCL as well, ulnar collateral ligament. So the DIPs, the PIPs, the MCPs of the thumb and the fingers. And every joint has a volar plate. But we only talk about volar plate injuries when it's the PIP joints, because they're the ones that we have problems with. We still get volar plate injuries at the DIP joints and the MCP joints, but we don't tend to need to treat them that much because they heal really well and maybe they just go unnoticed. But the PIP joints we have problems with. And that's why we say thumb UCL injuries, or if you say UCL injury of the hand, everybody thinks about the thumb. It's because we've had some problems treating them and identifying them, and it's led to us being more focused on that UCL than anywhere else, although there are UCLs everywhere. So this is how it looks. It's a sort of an abduction injury to the thumb being caught either by a stick or falling on the ground, and it leads to that lax joint. Having this scenario where it's really, really lax and the thumb just goes, actually pretty rare. So we would feel maybe increased laxity, we'd compare it to the other side, but that a lot of the time these people are in a fair bit of pain. So if they have a strong endpoint and they're not in pain, that's an easy fix. If they're really, really, we just manage that conservatively. If they're really lax and we can pull the thumb around and touch their forearm, well, that's very simple. They have to be fixed. But a lot of people fall into the middle of that. And they're the ones that we think about doing ultrasounds on to look for a stent lesion. And they're the ones that we compare with the other side and then make a call about whether that UCL is in a bad position and needs to be fixed. The reason that we have a problem with thumb UCLs is that the adductor aponeurosis, which is the muscle inside, it's a really, really deep muscle in your hand that you use for key pinch, supplied by the ulnar nerve, pops over to your thumb right at the position and runs right over the top of the UCL and inserts onto your extensor tendon. So everyone can sort of feel that when they do a key pinch. And if you pop your UCL and you break it enough, the adductor aponeurosis can sit in between the two ends of the UCL, and so it doesn't heal. And then we sort of, very hard to pick up on that clinically unless it's completely done. And so these people get put in a splint for 6 to 8 weeks and they come out of the splint, they're still a bit sore, you're living with a hand therapist, and 3 months down the track, they've got this wobbly thumb that should have been fixed. So the important thing is trying to identify who needs an operation early. And the good thing about that is that you create a more predictable natural history for the patient. So the patients who need an operation or don't need an operation, one of the benefits of an operation is that you create a predictable natural history of what's going to happen with hand therapy. And it comes of the risks of operations, which are things like bleeding and infection and failure and scarring. But if you have something that you say, well, I could put you in a splint, I'm not sure how it's going to go, it's sort of a bit 50-50, or we can do an operation, I know how it's going to go, basically. Some people will go for that. And some people will also like to go for non-operative, but understand their rehab after an operation. So we do that with ultrasound. And there's studies that say, oh, it's 50-50 about whether an ultrasonographer can pick a stenoid lesion. So if the adductor aponeurosis is stuck under the UCL, but it's probably closer than 90%. And it doesn't matter who you use. If you've got a musculoskeletal ultrasonographer, we use, we often use Fowler Simmons down in town because they're very good, but they should be able to pick that about 90% of the time. And this is sort of how we fix it. This one was fixed because there was an articular step that was sort of over 1 millimeter in a young person. But if that UCL is stuck to a big bony fragment, we can put a screw in it. If it's not on a bony fragment, it's just soft tissue, then we stick it back down. We put them in a splint and we give them a predictable natural history of how their hand therapy is going to go. The last thing I was going to talk about is wrist sprain. So wrist injury is sort of what I did my fellowship in and is of interest to me, but this is sort of relevant for teenagers and up, not potentially young pediatric patients, but more relevant as they reach maturity. Patient falls off a skateboard, immediate swelling in the wrist, might be sore for a couple of weeks, but then it settles down, but it's never quite right. The issue with an X-ray of the wrist is an X-ray just leaves so much unsaid about what's going on with the ligaments of the wrist. So here you can see that, the radius and ulna, there's growth plates, the scaphoid's in a good position, the lunate's there as well. And this X-ray is totally normal, but sometimes an X-ray doesn't tell you everything that's going on. This is one of our videos. I'll just try and skip past. So when you put force through your wrist, there's bones, but there's also these ligaments between every bone. So everyone probably has heard of the scapholunate ligament between the scaphoid and the lunate. It takes a huge amount of load from the capitate. There's lunate and triquetral ligaments, and then there's this TFCC over sort of distal to the ulnar head that's super important as well. If you put force through your wrist, you can fracture bones, and that comes up on the X-ray, but you can also damage these ligaments. And if the bones are in a good position, you won't see that on an X-ray. So an important thing, I think, if someone has a significant wrist sprain and their wrist is not quite right after a couple of weeks, is I would refer them for an opinion from an orthopedic or plastic surgeon who does wrist surgery, just to see whether an MRI is indicated. And occasionally you'll see, well, not occasionally, in adults quite commonly, you'll see these ligament injuries. And if they get picked up early enough and they get treated early enough with really good hand therapy, or sometimes with operations, they can do much better than if they're left and they get instability of the carpal bones that leads to arthritis. Because that is definitely treatable as well, but the treatment comes in the form of fusions, and that's a robbing Peter to pay Paul scenario where you take away their range of motion in order to treat their pain. So I'd just be conscious of wrist sprain as being sort of the tip of an iceberg situation. Never feel afraid to push it. Okay, my last 3 pearls for treating pediatric patients is, geez, that X-ray looks a bit funny. So I got sent this X-ray. I think they hadn't done a lateral yet, but they said this X-ray does look a little bit funny. And this is what we get in, this is sort of an adolescent, but we get it in a lot of pediatric X-rays because they're cartilage, and then they finally ossify when they're older, and there's not a lot to go on. So this was the AP, and then the lateral looks very, very strange with the head of the proximal phalanx that's sort of been decapitated and is dorsally. So my advice with these is, if you ever get an X-ray where you think, geez, that looks a bit funny, I mean, the guys in Adelaide, I'm sure the guys in other states have the people they go to. The guys in Adelaide can always just call us or text me a picture and say, what do you think of this? It looks a bit funny. Is it nothing or is it something? And we're more than happy to sort that patient out or see them or give advice straight away. because these x-rays can really throw you. And I had a case when I was a junior. I did an operation on child's finger where I didn't realize that the whole fragment had flipped 180 degrees and it had to be redone about a week later. So even when you're training and that's the thing that you focus on, we can all be tricked by these x-rays. So never feel afraid to sort of ask for advice about that. Elite children. Every child. So this is my bar up the top is adults who I've treated. I've treated some elite adults. Most of the adults I treat are total amateurs, and the other ones are basically accidents. The below graph is all the children I've treated. Every child I treat is elite in some way, according to the parents, and is some kind of elite sportsman in the making. Now, that can be super, like, a bit annoying because they're very conscious of they're in the state team in 4 weeks, or they're there's a state trial, or there's a SAPSARSA thing or whatever. And you have to be very, very rigid in how you manage those children and make sure that you stick to the plan of hand therapy, because if you let something slip and they have a complication, it's really inexcusable. But it does help, I think, with managing these children. If they believe they're sort of an elite athlete and they're going places, they're very compliant and they're very on board with their family. And already when you're a child, you're treated like a rock star. People make you food, they drive you around, you play sport like 4 times a weekend. So if they do that, the kind of hand therapy that an elite athlete would have, they get very, very good results. They all go through, every child that I've had who's really serious about sport, this is my child, goes through all these stages of their therapy after their injury. So denial, anger, bargaining, depression, return. 5 stages of grief, very, very standard. But they're great if you are talking to them in order to identify them and motivate these patients to do their therapy. And the thing about children and young adults and sports people is they will do very, very well if they follow the rules, because they're super motivated to get back to sport. So rather than seeing it as a detriment that every child or every parent thinks they have an elite child, it's definitely a positive thing. And it's really, really good to manage them if you know how to sort of motivate them. So that's all I had. So just to really harp on about the main points, nailbed injuries, super common. Don't miss a Seymour fracture. And a lot of them will have surgery in order to avoid complications of nailbed injury, which are really difficult to treat in a delayed manner. Mallet fingers are super common. Most of them just need a splint with therapy. Occasionally we operate on them, but we sort of don't want to, but we will. Volar plate injuries, they're from hyperextension of the PIP joint. We manage them with a dorsal blocking splint and therapy, but if they're unstable, we'll need to fix them. Proximal phalanx fractures, really, really important. They need lots of hand therapy. Beware of deviated fingers in children, because they probably have fractures through growth plates, not necessarily through the joint. Metacarpal fractures we'll try not to operate on because they do so well with just hand therapy. Thumb UCL, do they have an endpoint? Feel free to refer for an ultrasound for a stent lesion or look for an articular step. And wrist sprain, if a child has a wrist sprain, they've had a time in a thermoplastic splint or a time in splinting and they're still not quite right, just have a low threshold to get them seen. That's all.
Thanks so much, Nick. That was exactly what we see in general practice. So it's always really good to get a specialist opinion on things we see really commonly coming through our doors. I've got one question that got sent straight to me. It was from Cheyenne. She had an adult patient who had an index finger nail ripped off by a weight plate at the gym. She then put the nail back on and came and saw the GP the next day. How would you manage that sort of situation?
So the patient put the nail back on, did they?
Yeah.
Ruthless. Look, I would probably take the nail off and look at the nail bed, get an x-ray of the finger and make sure there's nothing weird going on, and then just dress it. So if you can see the nail bed, the finger doesn't have anything really going on at the germinal matrix, not too swollen and damaged, and the x-ray looks okay, then just dressings, should be fine.
Excellent. Looks like Lucy Monet's got a question. Lucy, do you want to ask away? You can just take yourself off mute.
Yeah, thanks. So This is a question about toes. I know you're a hand specialist, but you might know more than me about toes.
The toes of the leg. Yeah.
The little toe. I had a patient that had like a fracture of the little toe, and when it healed, it didn't heal straight. It's angulated now. What sort of angulation would be sort of acceptable, and when would you consider sort of breaking it up and making it straight?
On a toe?
On the toe, the little toe, because it catches in the shoes and things like that.
Yeah. So I think that would be, it would be very much a function-based question. So if they've got problem with, if they create a pressure area from that, if they're getting irritation from it, then they could consider having a closing or an opening wedge osteotomy, which they'd have to go to a toe surgeon where they'd have to make a cut over the top, break it, do an osteotomy, and put a KY down it. Yeah. So it'd be, I mean, unless they're a foot model, in which case they probably need to have it happen because they can't go on any more, thong commercials and things. It would be purely function based. Then I would say if it's not troubling them, not painful, and they can get it in a shoe, don't worry about it. But if it is, then I would send them to a foot surgeon. Yeah.
Thank you so much.
Any other questions, guys, about fingers and finger injuries or hands or wrists?
All good. That's totally fine. One thing I will say is that everyone can have my mobile. Feel free to text me any photos if they're weird. If patient, I mean, I'm at the Royal Adelaide, so patients don't have to have private cover or whatever. If they're public patients, we can get them into the RA quickly. If they're pediatric patients, we get them into the women's and kids basically the same day. Any problems at all.
Excellent. Thanks so much, Nick. That'd be really appreciated. We can I can get that out to everyone that attended tonight anyway. That's fine.
Sounds good.
Yeah. All right. Well, if there's no other questions, then I reckon we'll call that a night. Thanks so much, Nick. That was a great presentation. That was spot on.
No worries. Thanks, guys.
Thanks, mate.
Thanks for having me in your living rooms.
Yeah.
Thank you.
See ya.
Thanks, Nick.